Thank you very much. Assalamu alaikum. It's always a pleasure to be here, and thank you or the organizing committee for the kind invitation. Congratulations on a very exciting and well-attended conference. I've enjoyed the first presentations, which were evidence-based and data-driven discussions between surgeons and interventionalists. It's always enjoyable to see this. Speaking of evidence-based, this topic has very little evidence to back what we're going to talk about. And when you're faced with a left main thrombosis or acute occlusion, usually presenting as a STEMI with cardiogenic shock, it is basically a cath lab disaster. So with that, we're going to start talking about more concepts than cases. I had actually tried to find patients who presented with acute left main thrombosis who survived, and I called around and I found 2 cases, which I will share with you today. But I think most of the presentation is going to focus on what to look for, what the concepts are, and how we tackle this catastrophic situation. I have no conflicts related to this discussion. So the points of discussion: patients who present with acute left main occlusion in the setting of ST elevation myocardial infarction usually present with cardiogenic shock. And one of the major considerations is to establish mechanical circulatory support as you tackle the situation. With a big left main thrombus burden, thrombectomy should be a consideration. It is a class 3 for routine thrombectomy in STEMIs, but with a big left main thrombus, as we will see in one of these cases, I think thrombectomy is a very reasonable and advisable option in this case. Always be aware that with ballooning and intervening on a left main thrombus, you will have distal embolization, showering of the thrombus downstream, and you will end up with possibly no reflow phenomena. And then when you come to stenting, we'll talk about left main stenting, and this has been discussed, so I'm not going to discuss this in detail, but we'll mention a couple of studies that we will talk about. So when you present with ST elevation myocardial infarction, the burden of disease determines the outcome and the presence of cardiogenic shock. And as you can see here on the far right side of the screen, left main is associated with more than 70% presence of cardiogenic shock, and the outcomes are significantly higher when you present with left main occlusion, especially if it's a dominant left main or dominant circumflex. And as you know, cardiogenic shock is a dynamic situation. When you see the patient on the table and they're in shock, you need to be able to try to reverse this situation as quickly as possible before the spiral continues and you lose the patient on the table, which is a horrible situation. One of the major components of reversing shock is circulatory support, and you all know that this is something that is evolving. It also helps with ventricular unloading and ventricular support, and of course followed by coronary reperfusion and establishing flow and abolishing ischemia, which again tends to reverse the cycle of cardiogenic shock. Patients who present with left main occlusion are usually in the D to E classification. These are patients that if you survive the acute event with an acute left main occlusion, you are very, very lucky, and the patient is very lucky, and you have done a great job. Once you face a situation in the cath lab, you know you're in for a long fight. This is not a type A lesion where you go and balloon and stent and get out in 20 minutes. This is going to be a long fight. Options of mechanical circulatory support, you're all aware of the ECMOs and the balloon pumps and the Impellas, and I'm not going to go through this, but in our center, we are very familiar with the Impella, and we think it works fairly well in setting of acute cardiogenic shock. Balloon pumps are controversial, and the shock trial was negative, and the ECLS recent trial was also disappointing, had also disappointing results. One point to make on the left graph: if you think the patient needs mechanical support, please institute mechanical support pre-PCI, especially if you're going on the left main. I know that we all believe that reperfusion and time is muscle, but in the setting of cardiogenic shock, in STEMI cases, pre-PCI institution of mechanical support portends a better outcome for these patients. And with that protocol, we have improved our patients' survival with cardiogenic shock up to about 75%. This is data from Bill O'Neill. It's not randomized, but you'll all have access to this with the NCSI shock trial. So let's go through a couple of cases. And You'll notice that all of these cases are done through the femoral approach, unlike what we usually do with non-cardiogenic shock patients. So this is a patient who presents with acute left main thrombus. So this is an interesting situation. Patient clearly was in cardiogenic shock, so the impella went in first, and this is the situation that you're faced with. So as soon as you see this, you know you're in a bad spot, and the patient is definitely going to be a challenging case. One of the first challenges is actually wiring, because you don't see the distal vessel. So you start wiring, and a lot of the times you're wiring blindly, and you're trying to find the true vessel, and you're trying to find the distal LAD. As you can see here, this is something, and then the cases are running. So they wired the two vessels, and they did thrombectomy. And one of the options here for thrombectomy is to consider, number one, the larger thrombectomy devices. Penumbra is something that we use. The other thing you can do is you can engage the guide all the way to the thrombus and aspirate the guide directly, or use a guide extension. And this will yield the highest degree of thrombus removal for these cases as you go forward. So thrombectomy is recommended in such a case. And let's see if we can play this again. So thrombectomy was done and then followed by ballooning. This is, of course, afforded by the fact that you actually have an impella to support you. And there's an injection. And as you can see here, number one, you have a large thrombus burden in the left main. Number two, you have TIMI 1.5 maybe down the LAD. The more you inject in this situation, the more chances of distal embolization. And you'll see this as we go forward. And you know that with this situation, you're going to face no reflow phenomena. So again, more ballooning, you'll see the thrombus, you'll see the circumflex and the ramus and the LAD. More ballooning, more thrombectomy. And with this injection, you can see down the LAD that you have slow flow, you have distal embolization down here. I don't have them there. Down here, there's distal embolization of the thrombus, and there's TIMI 2 flow in the LAD. LAD trying to fill. And the one thing that they did there was, instead of neutralizing the thrombus or tacking it up to the side, they continued to do aspiration thrombectomy and injection. So the more you inject, the more distal embolization you get. And this was basically their strategy, was to go ahead and put a single stent with a provisional approach, with restoration of flow, LAD, left main. The circumflex, luckily for them, was preserved, and there was good flow down the LAD all the way down. So this was actually a case that survived with acute thrombus in the left main, with the impella and aspiration thrombectomy, and this is the final result. The RCA was not bad, which is something that probably helped the patient survive the situation. So another case. This is another patient, totally unrelated, in a different center, and you can see a thrombus, tight left main, LAD, in a dominant left system. You can see here that the left circumflex gives off the left PDA. Again, this was a patient that ended up with an impella, of course, thrombectomy, aspiration, ballooning, and final stenting, and this case was done as a DK crush. Imaging was emphasized in PCI of the left main, and this cannot be, again, overstated. It helps you determine the reference vessel. One of the things when you stent a large thrombus burden, as mentioned earlier in one of the talks, is as the thrombus resolves, you have a late stent malapposition. And imaging helps you determine the appropriate stent size before you do this. One word of caution for patients who believe that we believe they need mechanical support. This is an attempt to place an impella in a tortuous vessel, and this is the impella sheath, and as you can see that the sheath is outside of the iliac artery in the pelvis. And this was in the setting of an acute ST elevation myocardial infarction involving a left main stenosis. This case was aborted, and the referring hospital was sent to us like this and we ended up fixing the left main and putting an impella from the axilla. All right, so what we've done is we've discussed the acuity of the situation, how sick the patients are, cardiogenic shock. Thrombectomy is an option. You can prepare to deal with no reflow, whether adenosine or epinephrine, distal embolization, and your technique for stenting at the end, whether it's provisional based on the EBC main or it's DK Crush based on the DK Crush 5 study. So with that, I'll end, and I'm happy to answer any questions. Thank you very much for your attention.